really like to thank all of you all for coming here in such large numbers. It's very encouraging to see a room full of people wanting to listen to retinopathy of prematurity. I speak as my position of a program director of the telemedicine program in India, which is now expanding to some other middle-income countries, and also as a member of the National Task Force for ROP formulations in India. India and the problem of ROP can simply be defined by the huge numbers. I think we almost double that of our closest competitor in producing the maximum number of premature babies, and that's 3.5 million per year. What's more important is, I think the slides, can I go back, please? Back. Right, so the problem with India is that heavier babies and more mature babies, heavier than their counterparts in the West, are more prone to severe disease. And this is not just true for India, but middle-income countries, South America, and even Eastern Europe. We found that almost more than 6% of babies weighing more than 2 kilos at birth require treatment in this cohort of about 1,600 babies who were screened and about 175 that were treated, which is way above the screening cutoff guidelines, even in India, where we have a cutoff of about 2,000 grams. The menacing head of retinopathy of prematurity is now showing up in rural areas as well. Until now, it was believed to be just an urban disease, but now we find the incidence of ROP, even severe disease, is as high in rural areas as it is in urban populations. So let's look at the need, the want, and the requirement. The incidence of ROP varies from 37 to 54% from urban India. Rural India is not too far behind. And there are less than 15 to 16 institutions that comprehensively manage this disease. And almost all of them are in the bigger cities. Basically, this means that a whole lot of rural babies are exposed to the risk of ROP and therefore blindness. Around 8 years ago, we started KIDROP, or the Karnataka, which is the name of the state that I come from, Internet-Assisted Diagnosis for ROP. This basically relies on a platform of telemedicine in ROP, training ophthalmologists, and cross-support from other specialties like pediatrics and neonatology. KIDROP basically attempts to replace the so-called ROP specialist who uses indirect ophthalmoscopy and a very subjective science with a non-physician technician who is going to be validated and accredited to use wide-field digital imaging to screen for ROP in the outreach rural areas. As soon as an image is taken in the rural context, using the principles of pattern recognition, the technician will either look at an image and decide whether it needs treatment, needs follow-up, or is completely normal and the baby is good to go. This we validated over several thousand babies and have published it thereafter. Training is a very integral component of KIDROP, and we have them usually attending in pairs, one optometrist and one ophthalmologist together, because when they go back, one of them forms the backbone of imaging and the other one of reporting. A very busy slide, but basically to summarize our training program, there are 3 levels of technicians. They spend 30, 60, and 90 working days in our program, and at the end, as we've seen in our program, if you're a level 3 technician, the chances of you missing disease that require treatment is less than 1%. And that's because of their ability to even image the ora serrata. I think this has been a subject of a lot of debate on whether you can discharge a baby without doing an on-site indirect ophthalmoscope. And I believe we may have answered that question. With lower skill, your ability to get to the ora may be limited, but as your skill improves, you're able to recognize and image the ora serrata in more than 85% of cases. One of the other safeguards we have is that at least on two consecutive visits, the ora serrata should be imaged. One of those visits should be outside of 40 weeks of post-menstrual age. Fairly certain then that this baby is not going to go blind from ROP. Subtler disease like this stage 1 or more difficult calls like stage 2 with plus disease are possible as soon as your level of skill improves as compared to a level 1 technician. This is like a day in the life of the program. The a single device moves through many district hospitals. We have now 5 zones running in our state, and a few other zones run in other states of India as well. So basically, it's moved, taken to the local NICU. The technicians are taught to make the initial triage based on the color coding that I just spoke of. And then these images are uploaded onto a secure server, and the ROP specialist is viewing them almost real time and reporting them back almost in near real time to complete the process. The ability to look at these images on the iPhone, we showed, validated well enough with actually doing it on the RedCam system itself, and these were validated by on-site indirect ophthalmoscopy done by the ROP specialist. A more recent study of multi-centers from North America and Canada showed that there was a delay in their reporting. Close to 6% of their babies' reports turned up more than 2 weeks after the initial examination. Our turnaround cycle is less than 30 minutes. And I think this is a necessity in our condition, because in most places where our technicians are going, that is the only system of ROP screening that's available, and this is not an add-on. And so really, necessity is the mother of invention. We also have a low-cost, innovative way of enrolling babies from centers that we do not visit physically, but are in the vicinity of centers that we visit. As soon as a baby is found to be less than 2 kilograms, the nurse fills out this card, the top portion of which has in the local language information on retinopathy or prematurity, the requirement of screening, and a contact number of our program manager. And the lower portion has the mother's contact information. Using that, the project manager calls these people, the mothers, and schedules an appointment to the closest ROP site that our team visits, and this was published here. We also use images to communicate to the mother. And a group of mothers waiting for their babies to get dilated is a very good opportunity to talk to them about not just ROP, but other care practices as well. And we've used our help of our community medicine physicians to talk to them about immunization, breastfeeding, kangaroo mother care, and so on. And also, images help a long way in convincing them the need for follow-up. Treatment, wherever is required, is done in the rural areas. Our specialists travel to the rural centers, and we are training more and more local ophthalmologists to take on this program. Where this is not possible, they're brought into the headquarters and treated in Bangalore. Over 65 or 66,000 imaging sessions and over 19,000 babies now have been completed. Close to 1,300 babies have been treated in the program. Recently, we published our rural-only data of about 7,000 babies, and found that the incidence of ROP is close to 23%. The incidence of treatable ROP is more than 3.5%. But what's very interesting is the incidence of treatment requiring ROP is so different from private and government hospitals, much more in the private and lesser in the government hospitals, talking about the type of babies and the severity of diseases that they take care of. The financial model is one of 2 types. Either there is public funding, or there's private equity. Only 26% of our babies, parents of our babies, actually end up paying the full charge. But because of the large numbers we screen every month, we are not only sustainable, but we're actually profitable. In terms of the baby and the blindness burden it's saved, let's talk about the close to 1,300 babies saved alone. Just multiplying that by the per capita income and the life expectancy, it's about $62 million US compared to an investment of less than $2 million. So what is the expanding paradigm? The fact that we can image and detect, report, and treat babies with other conditions other than ROP while we're simply looking for the disease, and this came out here. Interestingly, more posterior segment diseases came out than anterior segment, and you can see some of these were highly amenable to treatment, and some others were not. The way this had to evolve was into universal screening, and probably India is the first government that's talking about universal screening of all its 27 million live births for 30 conditions. 2 of them belong to ophthalmology. 1 of them is ROP, which is a fairly well-defined program, and then all other eye conditions. We reported the first cohort of universal screening in India and found that the incidence was 4.8% of any abnormality and 1.6% of treatment-requiring disease. Some of these were self-resolving, others like this rubella retinopathy, which had life-saving heart disease, was not detected in a normal baby, was detected only because of this fundus image, and sent back to the neonatologist, and other surgical conditions that are very obvious here. If you extrapolate that to India, it means that more than 200,000 babies, so-called healthy and normal and term and going home the next day, might potentially have medically and surgically amenable requirement of treatment diseases. So what's the new paradigm? Middle-income countries sharing our demographics are talking about using telemedicine as propagating their otherwise unmet need for ROP screening. In a recent paper by Claire Gilbert and some of us from across the globe, we spoke about why there is a failure of an ophthalmology-led program. Some of these are listed very elegantly here. Either they don't exist, or where they exist, they don't exist adequately. So either you have difficulty in getting people to be convinced enough to do ROP screening or to do it well enough. And so possibly a neonatology-based led screening where either the pediatric nurses or the pediatricians and neonatologists themselves using cameras and then using a triage-based decision algorithm system where they're taking the image, they make the initial triage, then they upload these images onto a server, have their remote ophthalmology ROP specialist friend look at these and report them fairly live, is possibly a way we can deal with the expansion situation, especially in a country like India. Recently, more than 634 special newborn care units were installed in India, all run by the government. Almost none of them have ROP screening programs. There is a national task force, and there's a Queen of England has decided to invest in ROP research in India for the next 4 or 5 years, and together this large body is looking at how to take this forward. And one of the innovations that we're looking at is low-cost retinal cameras. Some of these are undergoing clinical validation in India. So the road ahead seems to be the low-cost camera, which is effective and yet wide field, a neonatologist or a local stakeholder providing these images, reading them on the triage, automated software analysis, uploading it to the cloud for remote reading, and of course, simultaneous training of ophthalmologists to take on the onus of treatment wherever it's required. The best part about being in the ROP business is that the only thanks we get are the smiles of the family and the babies that we form a small portion of in their lives to prevent blindness in them. Thank you very much for the opportunity, and I invite you to visit our Facebook page and our website.